And let's give this day something of a summary, but let's also move on besides the retrospective. Let's start out with the key takeaways from this day so that we could compare progress next year. Who would like to start? I believe we can start. We got ideas for collaboration, ideas on how to improve the process in Estonia, and we're excited about any potential collaborations. There are always new and surprising thoughts. You imagine how the event will roll out, but surprises occur every time. And we look very much forward to receiving private feedback from participants afterwards. Write to us to let us know what you would like from this event. We are doing this for the sake of the patients and their families. The Rare Disease Day is not intended for doctors.
Lähtun sellest, et mõned küsimused, mis siis tulid tegelikult enne online'is, aga millele võib-olla ei jõutud nagu vastata.
Based on the questions received online previously that we couldn't answer at the time. Let's start out. Do you believe the treatment journey of rare disease patients has improved after the creation of the Rare Disease Center? Yes, this is an excellent question. I believe this has improved, and I'd like to thank everybody who has been involved. On the other hand, I have to say that as an old school person, I always feel guilty that I can't help as many people as I'd like to, but my day has 24 hours. We would like to find a solution, as outlined by Professor Lutsar, that the state would be able to support us by letting us hire additional people for our team to help us get people on the patient journey. I'll take it from here and continue. The topic of treatment journey goes beyond rare disease. We have many inexistent or patchy treatment journeys, meaning patients fall through the cracks after diagnosis. Their treatment may have long gaps in them, meaning for the state that the person's treatment outcome will not be as good as it could be if the journey was smooth. And back to the first question, our takeaways from the day. The topic of lack of development strategies is an important one in my view. We have an oncology strategy plan until 2030. We don't have a rare disease development plan or strategy. The biggest killer in Estonia is cardiovascular disease. We don't have an action plan for this. Here, this is something that we, along with patient organizations, could nudge along and raise as a matter. I would come back to the key topic at hand today. How can we support patient organizations to thrive so they would remain active so that they could stand up for themselves? We know the initiative, the numerous patient organizations have been created based on parents' energy, parent initiative, but oftentimes the work ends because it's hard for a parent in such a complicated situation to uphold an organization or to manage it and to spread its word. So what do you think? What could help to keep these associations alive? How can society help you? Right. Good. I'd like to have a word here. It has been lovely listening to all of you today. As for in order to empower patient-centered organizations, we all know that patient organizations are born out of pure need. It's the patient or loved one who wants to unite people in the same situations they find themselves and to stand up for their rights, which is an excellent foundation. But I've worked abroad, I've seen a lot of patient organizations, and I have to say that oftentimes the founders of organizations are patients first. They are not always top managers, they're not the policymakers, they're not the medical professionals. They are people with an experience, which is their key value, but they might lack certain skills and qualities necessary for leading an organization, which may be why, as I said, these do not go far. The people's other obligations take over. And us, with their skills and qualities, we need to support patient organizations by helping them to develop these skills and the necessary knowledge. This could mean anything we know and know how to do. This may mean teaching them about how the healthcare system works, about how to achieve successful collaboration, about how to manage an undertaking such as this. And they should feel supported, they should feel, and when they feel confident, they might be able to have a practical input, a representative function. They might be able to give input in a more argumented and precise manner and to better collaborate with other specialists. Developing this collaboration doesn't mean dictating what patient organizations have to do. It means giving them the tools and skills needed to amplify the voice of the community. I would like to very much agree with what Mia said and to emphasize sustainable funding for patient organizations, umbrella organizations. These patients days have fewer hours for active work. Oftentimes now we expect the patient to drop everything and come to a committee for input at any time of the day, without considering that the patient may need to leave work for this and to give something up. We should consider compensation mechanisms and the practicalities. I'd also like to say that we need to decide who this we are. Who is this we that should help and support? Currently, this is an amorphous denomination. But continuing with the patient journey, Katrin Õunap, 32 years ago, you were one of the founders of the fenüülketonuuria association. What drove you to create such an association? Indeed, this was a long time ago. Many people may be surprised by this, but I was young and enthusiastic. I was a doctor at the beginning of my career. I was doing scientific research on fenüülketonuuria, and I was one of the drivers of the creation of this association. This was a time before the existence of social media. There were no Facebook groups in which to get together, but I felt communication was necessary, and I called people to come together in the same hall and asked everybody to get acquainted. And I felt the key thing I felt was that I, as a doctor, should not be in the board of this association that was founded, that this was something for the patients and the families. One of the things I did do was considering which people among the patients and families could be active and lead this effort. But the first leader had to leave due to their own health, the second due to their own unfortunate death, the second due to the death of a loved one. There was burnout, the effort, the time it takes, aside from a child with special needs, or like in the case of the first leader, she herself had a moderate to severe intellectual disability. The leader's daughter had an intellectual disability. It was demanding on her. And it's important to give them practical support, let's say accounting and so on. So what do you think is a bottleneck on the way to the creation of a specific rare disease association in Estonia? Tuuli, I wanted to ask you at the end of your presentation, what should we do with families with patients where there is one single family affected in the country, like let's say the Pitt-Hopkins syndrome? A single family or possibly two families are affected in Estonia. What to do with them? Where to send them? What's the association to associate with? We haven't debated this, but there may be no point here. It would be a clear waste of a resource to create a separate association for each ultra-rare disease. But there would have to be such a small umbrella to bring smaller groups together. Currently, they're spread out between larger groups. Some are in the muscular disease groups, for example, predominantly adults. But we have to think about this, but I think we'll be able to make up a solution to bring together the resource to share skills. I think small organizations can also have a lot of competences. Let's say one organization might have a legal competence, another some marketing competence. And if we were to distribute these skills around somewhat, we might be able to reach a much better solution. But again, the bottleneck is the resource. Resources, the reality, there are many other small networks or many other small groupings are based on the strength and effort of a single individual. And if this individual burns out, the effort collapses. But as you said, it's needed. Talking to decision makers, I found that they are altogether too comfortable. Making decisions is too comfortable because patients' voices are not heard. And saying in hindsight that the decision was incorrect is far too late. So while we have always asked our families to join us at this conference, is the same reason we want the decision makers in attendance to see the real-life stories with which they might never otherwise meet. So that's a reason to hear the voice of patients, right? But how would the work of the rare disease clinic be supported by the existence of various patient groups? Sometimes Katrin calls me late at night asking for a patient representative for an international association. Sometimes we don't have anybody to bring to board. We at the Children's Foundation mainly work with funding, although we have also taken on not limiting our efforts to the single patient we represent. We also try to find a solution for similar patients to follow. But for the Children's Foundation, I'd like to ask here that if there was a specific sum of funding for the heads of organizations, because this is work to be done because this is real and actual work. If they could be remunerated for their efforts with either money or something else? Would it help? We can ask the audience, is there anybody who thinks some specific funding would help? In addition to own initiative, right? But we all have to shop and we all have to pay for our shopping. It would be certainly payment would motivate, wouldn't it? It would be a new variety of motivation, but the fee would also motivate towards continuing the daily effort. It might decrease one very practical worry of being able to pay the bills next month. Indeed, in reality, families with rare disease, finances are complicated in any case. Between the treatment burden, between the services, between the medical appliances, while we have national discounts and means the burden goes beyond the burden on a regular family. I was about to say the same, what you said, Tuuli, and in addition, we can't expect all patients to be working and making a salary. For many, being diagnosed can ruin their healthy lifestyle. Can ruin their lifestyle, they might have to immediately rearrange their affairs. So possibly a lump sum of money might motivate them at different means. I have to say, as a starting out organization, it's hard to make the first steps without any funding. We have paid the initial fees, the state fee, the website from our own pockets, before membership fees. It's us who fund the effort. Now, never mind the money. The money is important, but if you don't have the skills, if you don't have any knowledge, where will you put the money? What's needed is a systemic, maybe I'm being naive, simplistic, but it would be good to have a system with maybe a collection of video materials with initial basic information on what to know and what to do. This information should be available in a single place. Because as you said, patient organizations are founded and run by patients who might not be able to work at all, whose time resources are limited, who don't have the energy, who might have problems with attention and focus. So gathering together the information alone would be complicated. This is an excellent idea. The materials should be available, but now also we have the materials, but nobody in Estonia or abroad knows. We might want to start raising awareness. We have international organizations to train, to teach, to inform, and yet there is widespread lack of knowledge. This is something we can change. We can raise the awareness. How to raise the awareness? As you said, the resources exist. Nobody knows about them. This means somebody has to go to talk to someone, to ask someone to put the information somewhere available. Who should do this? Would this be any of you? Now the question is whether we should try to share in the international materials or try to build our own Estonia, or to adapt international materials, or to create a platform to share Estonia. You might know more about who will take on this task, but certainly it's a complex issue. The Estonian Chamber of People with Disabilities already have a lot of video material intended to help in different phases of the journey. And we have been active in the patient information and skill dissemination field by informing heads of organizations about various matters to help them do the work, whether communications, currently AI literacy, trainings. We have covered a number of topics and we keep on mapping them. So as a large umbrella organization, we have been trying to contribute to hear the needs reflected just by our organizations. There are currently 2 patients who have completed training to become expert patients, and a couple more Estonians are in the pipeline. Whether we could adopt the same pattern in Estonia, I'm confident that this precise model is the answer, but having a training program for patient organizations aimed at the Estonian community might be quite helpful indeed. Coming back to my question, who should and who could fund patient organizations? Any ideas? Where would the money come from? We need money, but who, where, or how? Currently, the Chamber of People with Disabilities has the state as a strategic partner, and members of our network also receive some financing. But as I said, the time window is annual, 1 year, way too short for any planning. Secondly, I realize these are hard times, pressure from war, from a troubled economy, and so on and so forth. But ultimately, societal agreements have to exist to contribute. Untapped potential could be if we find financing from the state towards empowering and educating patient organizations, then firstly, potentially, we could be taking off some of the load from the state. What I've heard from our chamber networks is that when people receive their initial diagnosis and approach the organization, they have previously fallen through the cracks. They might already have an anxiety disorder from the stress of chasing a diagnosis. And now if the organization had the skill and ability to give some initial mental help, to offer some training and some direction, then potentially some of the load on the national healthcare system would be taken back away again. It would not only be an expense for the state. Sure, we'll take all the money you give us, but I can see clear additional value we could offer in return. And giving back would mean we would have more people able to work, able to participate in society and to contribute. Sure, but it still takes money. Yes. Right, let's move on. How could we also have Estonian patient organizations to join the EU organization Eurordis? Right, I'm awfully verbose today. During the break, we also spoke about this, about joining the umbrella organization and the opportunities it would provide. I think no persuasion is necessary. A topic I'd like to bring up is something we already mentioned today, research and doing research. I've already involved Tuuli, in addition to Siiri's applications and so on, in Europe, once applying for funding for rare disease research. Then there's a requirement to include patients all the way through the entire journey from the very first steps. The Estonian funding agency does not currently have this requirement. Do you think it would be useful that when making grant applications in Estonia, do you think it would be useful to involve the requirement of patient inclusion? Right, I might be able to talk about the patient orientation topic somewhat. For me, it all starts with treating patient involvement, not as nice to have, but as a basic necessity. Without the voice of patients, inclusion is in no way possible. They bring unique value. They map the treatment journey, not the journey outlined in documents, but the actual journey to treatment. They help us find the bottlenecks. They help us tell about how the diagnosis process and everyday coping actually works. As you said, we need to involve them from the very first step onward, because this is how we create a more caring and more financially sustainable healthcare system. You were talking about research, but let's say we have a disease called red nose disease. We make investments for years to make the red go away. And years later, we ask patients how it works. And the patients tell us the redness never was the problem. We can cover it up with foundation, but it's the itch that's the problem. So this is the pitfall we risk with when working for patients without involving patients. We risk with barking up the wrong tree, wasting resources. Coming back to the state level, decision makers need to see the families and hear the stories. As for the money, once everybody understands that there are savings involved, that we don't run multi-year projects to find out that they were useless in the end, then avoiding this would be another motivator to give funding.
Mainisid kaasamine, aga kuidas saaksime veel tervishoiusüsteemis süsteemselt tagada, et patsiendid oleksid võrdväärsed partnerid ja tulemused nende jaoks?
You mentioned inclusion, but how can we guarantee in the healthcare system that patients are equal partners and the results would be really meaningful for them? Well, this is what I said. We have to be patient-centered. When we include patients in every process, then they feel more included. They feel that they make decisions. And when we support them and develop their skills in the process, then we end up with better decisions and a better healthcare system. When we develop their skills, they are capable of making better decisions. So this is just something that we need to learn. Also, patient-centeredness doesn't come naturally. We are not born with it. This is something that we have to develop consciously, and this is why patient-centered development is also taught at different universities, because this is something that we need to develop. We have to learn how to communicate with patients, with patient organizations, how to include them, how to treat them as equal partners. This is how we can really cooperate. I would like to give an example of an international conference. I participated in the conference and they spoke about patient inclusion. I was sitting at the same table with the representatives of the Eastern European patients. And there was a very clear difference. The Western Europe had reached the point where the patient was a partner, part of the team. They were part of the project teams, and oftentimes it was the patient who was the head of the project team, if they were capable, of course. In Eastern Europe, what happened was that, yes, we are speaking about including patients already, but what happens in reality is that the patient is included in this red nose phase. We have solved the red nose problem. Come and see how wonderful the drug is that we have prepared for you. we don't include patients in the initial phase to decide whether this is actually the right course of action to take. This is something that we should take into consideration in policy making. We are included in many of the ministry's initiatives, but we often are being served something that has been ready-made, and we can see that, you know, what they have prepared doesn't really solve the problem we have. There's also the other side of the coin. Yes, we want to be included, but it all comes down to resources. We need support to contribute. Now, thinking back to your own experience, you just said that we are very far from the ideal situation, but how far are we? Thinking in years, I mean, it's a long journey. We have to take certain steps, but could we be there in 3 years if we worked really hard? I'm an optimistic person. I can see the developments. I can see very many wonderful cooperations between patients and doctors. I think that it will spread this tendency. I think that progress is inevitable. I think that in 3 years' time, we all do these things together, and this has become the new norm. Maybe coming back to the international perspective, yes, I do agree that maybe in some other countries the partnership is stronger. And I also have the pharmaceutical company's perspective, and things are very different there. A couple of years ago, in Sweden, we organized a patient conference. There were more than 60 representatives of patients from different countries, and we had them discuss different topics, and still the same problems came out. So I can say that we have the same problems here in Estonia as in other countries. All countries have their own problems, but there are still some things that we share. There are the same bottlenecks that all countries have to deal with. So I wouldn't say that we are far behind from others. The partnerships there aren't that strong either. Sometimes the thing looks better on paper than in real life. Elis Riin, how do you feel being both a student in the field of medicine, a future doctor, and then at the same time being a patient with a rare disease? Is it difficult to divide these roles, or does it help you become a better doctor in the future? It is difficult because I don't have as much energy as other people on my course have, but I would like to think that maybe I will become a better specialist in the future who is able to consider patients as well. There could be more role models like this, right? Yes, of course. As a person who has a lot of experience working as a doctor, then people and medical staff who have a personal experience in the field, it changes their perspective. But now I would like to talk about something else, thinking back to the health insurance fund. The treatment paths, they are the new thing in healthcare. So we have also been dreaming about writing down the treatment path of a person with a rare disease. In this project, we should definitely include the patients from the very beginning. And we would also like to receive input from them to hear about their real needs. So I would like to ask from the people here in the audience, for example, when we send an invitation, we ask you to come together and create an association, for example, for patients with neurodevelopmental diseases. Would you come? Would you join in? I haven't changed my views. I still think that doctors shouldn't be the people who lead these associations. I think if we create an association like this, it should be the parents who lead this. We know that we need this association, but we need your support here. in the project of treatment pathways, we have a couple of good examples of what has been done in Estonia. For example, the stroke treatment pathway, where patients were included from scratch. This is one of the examples that we can learn from. We can use their model as an example. There's a question to Mia Kukk. So you have experience from working in the Netherlands. How are patient organizations empowered in the Netherlands so that we could follow its example? To be honest, I was working in a regional center, so I have cooperated with very many different countries, but I would say that from the perspective of the pharmaceutical company, the main thing is to create different opportunities for cooperation. It's important to bring together different patient organizations so that they could learn from one another, because when they are together, they are more visible. Also, we include them in many different projects. There are many possibilities. We could invite them to participate in roundtable discussions, political discussions. Also, when we carry out an awareness-raising social media campaign, we don't have to do it based on information we find online, but we, as people who work in communication and marketing, we can include patients there so that they could tell us where we need to raise awareness. We need to include patients who have lived experience as much as we can in any of the projects we see. This would help. We have a question from the audience.
If you have questions, then...
Sorry, I'm switching with transcription. Okay, yeah, it's very interesting what you said. I think the good thing is, on those days now, you have model outside, model in Europe, model worldwide. I could say that it was not the case a long time ago. But yes, I do agree with Katrin. Doctors are not supposed to be the lead of patient organization, but a patient organization needs a scientific council, and that will be your place. And when you can reach that, you have a group of parents, and you have a group of a scientific council, it makes a fantastic work. On the other point, I would say for your country, we have a long experience in France, and the story of rare disease came from the families, from the Téléthon, from all those patient organizations, which mine was, because it was very at the early beginning. And in fact, it will all push past the family, and then we carry on the alliance. So we made a rare disease alliance because we were not strong enough. And then inside of it, I would say many small patient organizations grew inside of it and gets independency. So when you have one, you said about Pitt Hopkins, for example, one child who has Pitt Hopkins, I would say now with ERNs, you have the connection to put the family with, even so it's in Netherlands, it's in the British, whatever, it doesn't matter. And then maybe it will gather some other one. So it will help the family, and with IA tools, it's easy now to correspond. So I think the barrier language will be less complicated by now on for many families, but it's so needed for them to have this link of a connection with other family. So I think there is many, many models where you could get, and I would not recommend it. Some of the models I see now, would just as, I have a need, I have a patient, a child with a disease, a rare disease, whatever it is, and I just want to raise money, but I'm alone. You will not go anywhere, just for you, maybe to spend for your car because you have to adapt your families or whatever things. It doesn't work. Another point, I would say at a national level, I would rather also look like to mostly ladies who quit their job because of rare disease. But they didn't get retirement correctly. They do not have, when they go back to work, they do not have the same level of, of progression. So we should also think of the family on a national scale. And that's, even so, we're a bit advanced to you, and specifically because we are more people, that's it. we still have, I would say, all in the, with a racket, I don't know the name in English, whatever. So there is still some hole, and we have to get it. So you have models around you, and you have tools like UPATI, URORDIS, a National Alliance around you, who could provide this knowledge to the patients. And I can tell you, they have fantastic knowledge now.
Soovite lisada mingi kommentaari, vastata? Läheme tänase konverentsi selle pealkirja juurde.
Let's go back to the title of our conference today. When the patients whisper, the decision maker remains silent. When you think back to recent years, can you think of situations where if patients had made more noise, things would have happened differently? Maybe I'll talk about cystic fibrosis. We were fighting over the treatment for cystic fibrosis for years. I am deeply grateful to Janno Puhsepp and the association, but he was basically all alone fighting for this medicine to be available. Launching this took time for all of us. We, as the Children's Foundation, we supported with our campaign at the very final stage. Then the matter was taken to court, and it was only then when things started to improve, or this is how we understood it anyway. So it seems to me that, as I said before, it's the comfort zone. Decision makers think that, you know, the patients won't make a noise anyway. There are a couple of people there, they won't make trouble. But when we join our forces and we bring up the same topic every day on a constant basis, it's only then that we reach the solution. This is why we need strong patient organizations, and we need cooperation. Unions are maybe not a very good example, but for example, when train drivers protested, then bus drivers joined in. So we should also stand out for each other and be together. It's the same cooperation that has been discussed a lot here today. This is evident in medicine and medical studies, which Elis Riin mentioned in her presentation. I'm also teaching future doctors, and we are always told that future doctors need to know the most common diseases. Rare diseases aren't something that are emphasized in their program, but actually 7% of all diseases are rare diseases. And if a family doctor is substituted by a doctor of internal medicine, then they have no knowledge on rare diseases. Okay, we don't have to teach them very thoroughly, but doctors should be aware that these diseases exist. Recently, we had a development conference at our university hospital where I spoke about the Competence Center of Rare Diseases and the register, and they told me that, you know, this is just a small percentage of patients, but these patients need help as well. So people try to push us aside and talk about big diseases like cardiovascular diseases and cancers. And also something we need to consider is that there are few people with rare diseases, but when we add families who are affected by the care burden, we add the siblings of children with rare diseases who are being affected by it, then actually the number of people who are affected by rare diseases is quite big. It's a lot bigger than we can imagine. We had a media training recently for the patient networks, And they said that it's good to bring visual examples. For example, when you have 30,000 people with a specific diagnosis, then this is the same number of people as we have in the town of Viljandi, or in the town of Narva, or in the town of Tartu. Are we just willing to get rid of this town full of people? When we give these numbers an actual visual image, then this is people understand it better. I am Marja from the Estonian Chamber of People with Disabilities. I hope that you don't think that the parents of people with rare diseases don't want to come together and establish these organizations. In I also know parents who have children with rare diseases, because I have children with rare disease. So what we did with another mother who has a child with rare disease, we created an association of people with special needs. And I have to say it was very, very difficult. I can't believe that we managed. It's a great responsibility. You might think that, okay, I will also follow my own agenda and you want to make positive changes. But actually, people have expectations. They expect you to solve their problems. Maybe here, you know, me and Laura, we have the same idea, the similar understanding of the topic. But some people understand things differently. Some people come and start hindering our process. So with our large burden of care as parents of children with rare diseases, it's not easy at all. Also, what takes up a lot of our energy is communicating with different people regarding my child's diagnosis. I'm constantly talking to different specialists from Poland, from Germany. We communicate to each other all the time. Families who have children with rare diseases, we talk to each other all the time. But it's not very easy to come together and, for example, establish an association. There are very specific issues here that hold us back. I also wanted to ask something else during another presentation. So, Marko, you said that you have no idea where the money comes from. Well, I actually have some ideas. How? Maybe the health insurance fund should increase people's own responsibility for their health, so that we shouldn't spend so much on lifestyle diseases. And then we could free up some funds and direct them to treat rare diseases. So there are different options. It's the question of priorities. There are many question marks for me. For example, when patient organizations are being asked in the parliament, for example, where should you get the money from? To be honest, it's not my problem. I don't have the state budget Excel tables. It depends on our priorities. I was supposed to leave 20 minutes ago, but I just texted my husband and told him to pick up the kids by himself. So it has been a very interesting discussion here today. If we invest into patients, their voice, their representativeness, and take them as good, strong, and equal partners, then actually this is beneficial for the society. Yes, it might take 10 or 15 or 20 years, but it will pay off. Marko, you told me a couple of days ago that dealing with lifestyle diseases is also a long-term project. So basically, I don't know, maybe we should drink less alcohol, smoke less, sit less, so we would have less or fewer lifestyle diseases, and we would have more money for rare diseases. I agree. The people who want to smoke and drink, it's their decision. They could take the responsibility for it. There are more questions. So if a patient asks to be included or even asks to be heard, then they tend to not listen to the patient. Who should be the one taking the patient seriously? Do you get comments like this often? I hear very many different comments and complaints, and many of these complaints are related to communication skills, and it happens both ways. Communication is always a dialogue. It's not that I think that I am having a dialogue. Actually, I'm just talking at somebody else, and at the same time, they think what they could talk at me. So we need a dialogue. This is a skill set that hasn't been taught in our medical system. How to communicate to people with special needs. How to communicate with people who have behavioral issues or psychological problems or a very high level of anxiety, because in this case, they are not able to receive any information. We have to calm them down first. How to communicate to people who have hearing impairment. I will give you an example of why these nuances are important. We had a meeting with people with hearing impairment to map their problems, and they said that when they go to buy their medicine in the pharmacy, then instead of trying to communicate very discreetly, the pharmacist tries to speak more loudly, and sometimes they even shout, and sometimes they talk about very discreet matters so that the entire pharmacy hears. This just boils down to communication skills. This is something that we need to learn. The same applies to patients. Sometimes we as patients, we are very sensitive because we are often very vulnerable, so we interpret the situations differently. I am not the frontline doctor, but we can always say that if you're not happy with your doctor, get a different one. But as we don't have many doctors in Estonia, we have a lack of medical staff, but I think we still have enough specialists to get a second opinion. Of course, this path is very long, and there is a possibility that somebody makes fun of you or shames you or doesn't take you seriously. There is always the possibility that you find the right person who listens to you. And this is what we have done in the Chamber of People with Disabilities. We've organized many different training events. And something that Katrin also emphasized, something that's very important in communication, is the treatment relationship. A good treatment relationship with a doctor is something to hold on to. Right now, our system says that if you couldn't get an appointment with your doctor, turn to a different specialist in another town. But this means that you would have to start explaining everything from the very beginning. When you see one and the same doctor all the time, then you understand the issue in the same way. This is the perfect world. I have examples from my own family. People who are tired, they have given up, they have stopped asking for help. They have told the story, nobody will listen to them. They are being referred to a different town to see a different specialist. They have to take a day off work, and in the end, they don't really bother anymore. So we have 4 final minutes left. How should we empower patient organizations? A couple of sentences from everybody.
et siis oleks veel rohkem nii-öelda nagu positiivseid asju, millest rääkida ja muretada. Kuidas võimestada?
How to empower patient organizations?
Okei, mina alustan.
I will go first.
Ei ole ju patsiendiorganisatsiooni esindaja, aga
I'm not representing a patient organization, but I think that we should get things done.
Räägime Lahra laugu pähe,
Let's
leiame selle raha,
find
mille eest talle palka
the money,
ja teeme
let's hire her and let's get something done. Otherwise, when we just move air here and there, nothing will change. The other thing is something that I've been speaking about for more than 15 years. We should teach future doctors to communicate. We really need it. It's very important to create trust. We understand that it's not only the doctor who is on the treatment path. It's not only the medical staff, but for example, the Children's Foundation also funds or also employs a social work coordinator in the Children's Foundation. It's very important for the patient who receives the diagnosis and everything that comes with it. It's important that there's a person who helps them. So let's just get some things done. I agree with everything that Siiri said, and I would just like to add that we have to have a long strategic partnership and sustainable funding. Also, we need to have some sort of an action plan or development plan for rare diseases. What could we do to have it? Well, we could just ask different people to come together and get started. And then the third thing, treating pathways. This is something that we should push forward for things to improve. Yes, I agree with the previous speakers. Let's get things done. I welcome all parents who are here today or who are following us online. I encourage you to write to me, and I would like to bring you together and get something done. We can give you the know-how. I have started 3 organizations in my life, 2 professional and 1 patient organizations. I know how to get the funding, and from our team, from the Competence Center, we will continue developing the treatment pathway for rare diseases. We have plans with the Health Insurance Fund. I would like to say that when you have the people, you have the long-term plan, and you have started doing things, then I would like to add something. This is a principle that the patients have said, nothing about us without us. When we do something, let's include the patients from the very first step. This is how we create value. I would like to repeat what I said before. Information should be in one place. The information that's necessary to start a patient organization, information about how to do it, about the counting, and so on. And I would add that it would be useful to have know-how, how to cooperate with medical staff, with social work coordinators. So, for example, when a member of our association has a question, then we know where to look for the answers. I think that cooperation is very important. Thank you very much. We had Tuuli Seinberg from the Estonian Chamber of People with Disabilities, Siiri Ottender-Paasma from the Children's Foundation, Katrin Õunap from the Estonia Association, Mia Kukk, who has international experience working in a pharmaceutical company, and we also had Elis Riin Tars-Hurt from the EDS Association. This is all for now. Thank you, all the presenters, all the people who asked questions, all the people who were thinking along, who make an effort. This is a very complicated journey, but they still smile, and we have to smile because positivity moves us forward. Thank you.